Good afternoon, everybody, and welcome to NCUI's Peer-to-Peer Solutions Center, Chaha'oh Gathering of People. Today, we're going to be focusing on the future of telehealth. My name is Liz Best, and I am a public health manager here at NCUI. I'm also joined by Molly and Sabu, public health associates at NCUI, and Sean Bitsui, who is our comms lead for this program. Also honored to be joined by Beau Boryca, from the Nebraska Urban Indian Health Coalition. At this time, we kindly ask that you place your name, your organization, and your tribal affiliation into the chat box so we can get to know you a little better. In addition, we welcome any feedback you would like to provide about this webinar experience in our survey, which will also be posted in our chat box. Next slide, please. We would like to thank you for volunteering your time today to participate in today's discussion. We at NCUI appreciate your willingness to share your UIO experiences and the work that you do in your communities. I also want to bring attention a brief disclaimer that this event today is made possible by the Indian Health Services. We are honored to have you all here today. Next slide, please. For those of you who are unfamiliar with the work of NCUI, here's a little background. The National Council of Urban Indian Health, also known as NCUI, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indian and Alaska Natives living in urban areas. NCUI is the only national representative of the 41 Title V urban Indian organizations under the Indian Health Service and the Indian Healthcare Improvement Act. NCUI strives to improve the health of over 70% of the American Indian Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. Next slide, please. Just a note, please note that the session is recorded for educational and quality improvement services. Next slide, please. As we dive into our session, here are a few things to keep in mind. Please turn your video cameras on. This event is meant to be interactive in nature. You're muted, but at the end, we'll have time for questions. But if something comes up, please feel free to put it in the chat box. Molly will be monitoring our chat box, so feel free to drop any questions or comments throughout the presentation, and we'll address them at the designated time. If you have any technical issues at all during today's session, please place your query in the chat and a NCUI staff member will assist you. Next slide, please. As shown on our agenda, we will begin with a brief overview of the Chaha'oh, followed by our learner objectives, introduction of our presenter, telehealth background and resources, today's lecture, and then finally, our opening discussion. We will close the session at 3 p.m. Next slide, please. A little bit about the title of our Peer-to-Peer Solutions Center. A Chaha'oh, for those of you who don't know, is the Navajo word for shade, shadow, or sun shelter. A Chaha'oh is rarely finished because it requires constant care. It is a warm and inviting place to gather, to socialize, to listen, to laugh, and to cook. We hope you find today's session an inviting gathering space to share your thoughts and ideas. Next slide, please. So our learner objectives for today, we're going to be discussing shared technology considerations that impact the telehealth experience for patient and provider. We're going to identify and share opportunities for telehealth to improve patient care and discuss gaps to be filled to provide that care. And lastly, we'll share benefits and challenges of using telehealth technology. Next slide, please. Although we all certainly have an image in our minds of what telehealth looks like, I thought it might be helpful for us to share a working definition. Telehealth is defined as the use of electronic information and telecommunication technologies to support and to promote long-distance clinical health care, patient and professional health-related education, and public health and health administration. Technologies can vary and include video conferencing, the internet, store and forage imaging, streaming media, and terrestrial and wireless communication. Next slide, please. And today we are curious to learn more about your telehealth programming that you are currently using. Do you currently have a telehealth program within your organization or clinic? If so, please drop a thumbs up in the chat. In fact, 17 out of 41 UIOs report having telehealth programs. That's 41%. Next slide, please. Many of you may have started a telehealth program during the COVID pandemic. I know that Beau will expand on his organization's work in this area, but did you know that prior to the pandemic, telehealth represented only 1% of the total healthcare volume in the US? Yet within the first few months of the pandemic, more than half of physicians used telehealth for the first time. Subsequent research shows physicians have overwhelmingly responded positively to telehealth implementation. In fact, 85% have indicated that telehealth increased timeliness of care, 75% said that telehealth allowed them to deliver high quality care, and more than 70% were motivated to increase telehealth use. Next slide, please. So COVID-19 was not the start of telemedicine, but its implementation was crucial during the pandemic. Telehealth helped reduce unnecessary exposure to COVID, helped to mitigate the spread of the virus, and reduce surges in hospitals and clinics. Next slide, please. So there are many creative ways that your organization can use telehealth. A few ways are synchronous, which can be live two-way audiovisual link between patient and provider. These can include video evaluations or a real-time care plan. Can also include phone calls to discuss symptoms with a patient. Telehealth applications can be asynchronous, which can include texting between patient and provider, patient report sharing, symptom surveys. Can also include remote patient monitoring, which has been really successful with regard to blood pressure monitoring diabetes care, treatment for obesity. And lastly, it can include mobile health, which can include healthcare and public health information being sent through mobile devices. Next slide, please. So why use telehealth? Research has shown that telehealth can reduce health disparities. It can make more opportunities for patients to connect with providers who come from a similar cultural background. Telehealth can provide access to care that was previously unavailable at your clinic. It reduces travel costs for appointments. Less travel time for appointments also means less time away from work or family, making it more accessible. And also, lastly, more confidence for patients who are willing or who are unwilling to seek out in-person behavioral health care because of stigma, but they might feel comfortable with telehealth. Next slide, please. So just quickly, here are some elements of a successful telehealth program. It's always important for the initial visit with patients to be face-to-face to establish a relationship with patient and provider. It's also important for patients to see the same provider at follow-up visits, ensure ease of access to the telehealth program, provide an overview of what telehealth is and what to expect. Also to confirm that your patient has access to the internet or time available on their data plan. And I know Beau's going to expand on how his organization was able to do this. And lastly, training for staff and continual training of staff in telehealth platforms is really important. Next slide, please. And before I pass the mic over, I'm sharing some telehealth toolkits which can help you get started or think about some best practices. I know Molly will drop these in the chat box, but take a look after this presentation, and all of today's information will be provided after the webinar as well. Next slide, please. And with that, I am super thrilled now to announce our presenter for this session, Boryca. He will be discussing the future of telehealth and answer any questions you might have at the end of the presentation. Beau is currently the Director of Behavioral Health at the Nebraska Urban Indian Health Coalition. He has been with the coalition for over 11 years. He's a licensed mental health practitioner and licensed drug and alcohol counselor with the state of Nebraska, and he serves on the Nebraska Joint State Advisory Committee for mental health and substance abuse. He's also the president of the Great Plains Behavioral Health Directors Association. I will now turn it over to our wonderful presenter. So please welcome Beau by placing a heart emoji in the chat box or using a reaction of your choice. Thanks, and take it away, Beau.
Thank you, Liz, and thank you everyone for attending today. It's an honor to be here in front of all of you. Next slide, please. So like Liz said, I work at Nebraska Urban Indian, and I just kind of wanted to give a brief overview of what telehealth is, what it's done to our practice, and how we went about implementing all that, and some of the thoughts and considerations we put into this program when we started it back in April of 2020. Next slide, please. So as everyone knows, COVID-19 has brought about all sorts of changes to the workplace. Not only how we see patients, but how we operate, whether we're in office or at home, whether we're in a hybrid situation coming to and from the office. A couple of things. A lot of people have a negative outlook on COVID-19, and there definitely is those negative impacts that we've had, but it's changed the way we do business, and sometimes that's for the better in terms of the care we provide to our patients. Early on in 2020, Medicaid and Medicare really stepped up and allowed for us to not have to do these face-to-face visits so we could get reimbursement for services. Even furthermore, when we talk about telemedicine, the work that the DEA did to where people could get prescription drugs, very specifically controlled substances, through a telemedicine visit instead of having to go in office for the first time to get those, narcotics or whatever substances or medications that people needed. Next slide, please. We can't talk about COVID-19 and telemedicine without talking about the disproportionate impact it had on people. One thing I always like to bring up, the people we serve, and Nebraska Urban Indian has multiple programs that serve multiple populations. Our residential program, for instance, is Native American specific, but our outpatient program serves the greater Omaha metro area. And when we say that, we serve a lot of the underserved people in this community, and we're honored and privileged to do that, but we can't do that without acknowledging the disparities that different people are affected by. We'll often run into issues with just access to healthcare. Nebraska Urban Indian has done multiple things over the past couple of years to try to address that. We just moved into a new facility. I know you guys can't see it, but you can look us up online. We're going to be opening our primary care clinic here in March. Why is that? It goes back to the disparities people are dealing with in getting access. I don't know if anybody's looked to try to get a medical appointment. If you're calling today to meet with your provider, you are probably not going to be seen this week. You're probably going to be scheduled out. And that's not just here in the Midwest, that's nationwide. Some of the other things we see when we talk about telehealth is access to Wi-Fi services, dealing with comorbidities. They don't only need behavioral health care, but they need physical health care as well. And as simple as having clean running water. The primary populations that we do serve are Native American, African American, and the Latinx community here in South Omaha. Next slide, please. When we talk about telehealth, we can't ignore the fact that a framework for Indigenous specific determinants of health, it comes with its own problems. When we talk about the majority of people in this country who have white ancestry, how they learn and operate is much different than those who were here before us, before colonialism and everything else. What I'm saying when I talk about that is how people learn, how people grow, what people need to nurture is different based on race and ethnicity and everything else. The determinants of health may be biological, behavioral, sociocultural, economic, and ecological. When we want to address those specific frameworks, we really need to look at focusing on changing underlying structural determinants and focusing on strength-based perspectives that celebrate connection to either land, their community, interpersonal relationships. Those are the things that mattered. And as we talk about COVID, that pulled us completely away from that. We were in a shutdown. You're supposed to isolate. You're not supposed to get out, within the community, no social gatherings. And that was one of the biggest things I realized in our organization as we're dealing with COVID and people are passing. How are we supposed to honor those people? We're just still doing memorials from back in 2020 that we weren't able to gather for. And the impact that had on the family. There's no closure. Things are just left and often forgotten. Next slide, please. Now, again, we're talking about the negative. There were benefits for the people we serve. And Liz talked about cost reductions, expanded access to services, behavioral health, and other chronic disease specialists. It makes a big difference when we're talking about specialty care, when we need a 15-minute window and we can see 4 people an hour religiously versus going into a healthcare setting, appointments running long and everything else, the to and froms. It helped us close the gaps in health condition recognition, diagnosis, and treatment. We have improvements in care management. I don't know about anybody else in the room, but I feel like most of my day is spent on Zoom. And the amount of meetings I can get in a day is drastically different than pre-pandemic. If I had 3 meetings in a day in the community of Omaha, that tied up most of my day just because of the travel and everything else. I'm sitting in this office today and I had 3 meetings this morning and I have 2 more this afternoon, and I'm getting twice as much work done with little to no effort. Next slide, please. With telehealth, we do run into barriers with our clients. The differences in age. I have 2 little kids at home, and I'm pretty sure my 5-year-old operates that iPad more efficiently than I do. But if I take it up to his grandma back on the ranch, she's not going to know how to operate that thing that smoothly. Level of education impacts everything. Computer literacy, bandwidth. I know with the Great Plains, we were talking about having a behavioral health conference in 2020 and not understanding how bandwidth affects an agency as we're trying to expose people in the 4-state area, which is North and South Dakota, Nebraska, and Iowa, how these agencies that are operating that have internet, but they don't have the capability to have 10 computers pulling on Zoom simultaneously without being kicked off. Just lack of awareness. What is telehealth? What is telemedicine? If somebody would ask me what telehealth was to me back in January of 2020, my knowledge base and scope of that question would have been very small. It's since changed, as it has for most people. High expectations of users. When we started this program, we had an expectation or thought that, this will be simple. We'll be able to get equipment out to people and we'll be able to continue doing what we're doing. That was a farce, and I will discuss that more later. No phone, just not having a smartphone. Socioeconomic status, who can afford this, who can and can't get access to this. Gender differences. There was an article put out a little while ago by Athena, and they were talking about just gender differences in people where women are more apt to engage in telehealth services where men are not. And they've measured that over the past 3 years, and it still stays true to this day. And just preference for personal communication. I, for one, was one person at the beginning of this that said, I'm going to be that person who would want to be in person. And quite frankly, that's how I wanted to operate. I felt more connection through this process, or when I was in person versus going through this digital divide that we're dealing with. Next slide, please. As we talk about this and we talk about implementing programs, we can't forget about our staff. Adopting a practice of telehealth was interesting, to say the least. I don't like saying difficult because we managed but there were some things we had to take into consideration. I had staff at that point in time that were still handwriting notes. We had paper files, they were handwriting notes, inserting that into the file. People just don't want to change. Change is hard. Change is hard for everybody. As much as we are providers, in behavioral health, and we talk about change and we want people to change, sometimes we're the most stubborn people to actually change. Licensing, how do I get licensed to provide this kind of care? How do I get reimbursed for this care? Perception of impersonal care. Some people thought in the beginning that, well, it's not going to be personable. They're not going to be able to do, trauma-based therapy when they're looking at a screen. Information overload. This was a crash course in computer literacy that I did not anticipate with a lot of my staff. I think before the pandemic and before we did all this training, I had 2 staff across the organization or in behavioral health department who had webcams and utilized them on a semi-regular basis. Today, we have a webcam on literally every device at every workstation. Any open computer has that ability. Next slide, please. So I'm going to talk about our story, and I hope I don't get too lengthy with some of this, but in March of 2020, we knew the pandemic was coming. Now, granted, we're in the Midwest. The Midwest is the last to be affected by anything, especially when it comes to change or problems. It's kind of like, we're spread out. We don't really see the impacts that the coastals do. But as we were watching this on the news, and I very vividly remember sitting in Dr. Polk's office, and she's watching something on her computer, it must have been CNN or something, and they're saying, it's coming, it will get there. And I remember her looking at me and saying, what are we going to do? She was very forward thinking and reached out to a contact she had at the University of Iowa, who put us in touch with a telehealth therapist who was offering training on how to do telehealth care. And again, the University of Iowa, they're a blessing in disguise, because they were like, you know what, I think we can pay for this. So I had my entire staff participate in the training, and we started at the end of March. I would say like the last week or 2 of March. And by mid-April, every staff had been trained. They knew all the things to pay attention to. We had all the equipment, and we were ready to go. And that was about the time when we started getting cases in Omaha. And before long, by the end of April, we were 100% telehealth. We had closed our doors, said, this is how we're going to move forward. We're no longer going to see people in person. And everything stopped, because now people can't come in. We run into the scenario of, okay, how are they going to see us? How are we going to make this work? Because not everybody in our community had that access. Omaha Public School System is one of the biggest school systems in the Midwest. I think they have 53 to 54,000 students. They were scrambling to buy iPads for every student so they could do telelearning. And we were like, we can do that. Let's see if we can buy a bunch of tablets and create, fix this and provide a solution to every client that we serve. So we ended up getting a grant through the FCC to be able to purchase this stuff for people to get health care. We were able to get smart devices to measure, blood pressures, diabetes, whatever else, but we could put these in the hands of people. Now, putting them in the hands of people solves one problem. It doesn't solve the other of how do they turn that on? How does grandma communicate with us through that when she's never had a smart device before? So again, learning as we go, we start creating handouts. We're going to people's houses, keeping our social distance, wearing masks, giving tutorials on a front porch. We're also talking to grandma and grandkids, because she's taking care of them, and explaining to them how to use it. Most of the time they were telling us, yeah, we know how to do that, just hand it over so I can play my video game, which brings some laughter. But the heartwarming part of that for us was we were able to see how important it was for them to have that access, and how they could communicate with family through that device, because we paid for 3 years of service on those initial devices. So their data plans would last for the next 3 years and they wouldn't have to miss a beat. Now we've put these devices in everybody's hands, and we say we're going to send you, links. This is how you're going to just click on the link and go. Great, that works. We partnered with Let's Talk Interactive. They were able to, get us connected, but we forgot we're behavioral health. We have a mountain of paperwork that thick that has to be filled out. So our partners at LTI really helped us in terms of digitizing every piece of documentation we had. And we were able to set it up in that system. So the first link that people got, they were able to click on it and just plug and play, click on things to fill out these forms. So we had permissions. I didn't realize, as we're going through the training, I'm like, yes, it's important to have consents. Well, now we're consenting to not treat you in our office. We're treating you at home. We're treating you in a parking lot or in some public area in a private space. And those consents have to encompass all of that. Not only that, we learned that we need to have codes for, hey, if somebody walks in the room, you can just let me know by tugging on your ear that somebody else has walked in, just to keep things private and confidential. There were a lot of little nuanced things. Again, learning on the fly. Our training was great. It told us how to be a therapist and work with somebody. And they shared some of these issues we may run into. But when we were learning, we weren't, this individual did all of their telehealth virtually, or telehealth practice 100%, but we did not know that we were going to have 120 clients on our caseload day one, and all the differences that each one of those individuals or families were dealing with were different. So again, a lot of learning on the go, but then as you can see in my slide here, resistance. Therapists getting frustrated. Things aren't working as smoothly as they want. It's now taking us longer to get through these processes because we spend more time teaching and case managing than we actually do therapy. Granted, that has always been my MO as, the director of behavioral health. We are going to do whatever's necessary, but I had some therapists who were on the verge of burnout because of all the excess work. We did lose a therapist or two through this time span, and not because it was a bad work environment. They just said it wasn't for them. They wanted to do things differently, which is fine. This wasn't going to be for everybody. But for those who stuck with me, we sit here and we smile about it today because that was a very trying time for us. And not that the work was too hard, but we had patients we cared about and wanted to see and make sure that they were getting the care that they needed. And that's what was the driving factor for all of us. That's what motivated us to take the extra time and do those extra steps. Staying connected, helping people understand that, yes, this device should be utilized for therapy, but if you need to get a hold of, your auntie or your nephew or whoever else that matters to you, use it. This isn't just for us and just for this process, and that's what I'm saying when we talk about understanding a culture and what is meaningful to people. Yes, therapy is important, but it's not the end all be all, because who are we if we don't have our family or we don't have those people we care about in our lives? Life gets pretty drab if you're only going to talk to your therapist and that's it. We also learned that we have a lot of common practices when we do telehealth or when we do therapy in person. Some of us smudge with our clients every time they come in. Well, now they're not here. How do we do that? Nebraska Urban Indian, and I brought it with me today, bought a bunch of smudge kits, and we send them out to all of our clients. So we were still able to do some of those common practices that we had while we're doing telehealth. You just had to think on the fly. And I'm very fortunate with this organization that we will go that extra mile. We will provide that. Yes, that's not something that was in our budget, but if there's a will, there's a way. And that's how we tackled all of this. That, they can't attend talking circle because you can't have groups of more than 10 people. We had private talking circles within the community that were held over telehealth. And we had ways of going about passing the stick and being able to speak and being private and allowing people to still get their needs met. We used the internet a lot for letting people know when gatherings were happening or how we were going to do it. How are we going to do it safely? Providing meals, all of that. And I tell people, I said, if it wasn't for telehealth, this would have been a lot more complicated of a problem, but we were able to do it safely. We were effective in what we did, and we grew from it. I often laugh when we opened our doors back up with our residential program. There were a lot of things early on, having people in isolation for 7 days. Well, how our old facility was set up, that meant they were going to be away from all staff. Well, shoot, now we have all these devices. We had live feeds going all the time to where they were communicating with us regularly. We were able to do it safely and then open our doors and bring people into group settings. Granted, our capacity was lower, but we were still effective in terms of providing care. That reopening piece was always a little bit scary. There was a lot of worry about how we would do that, but the telehealth capabilities really changed things, especially when it comes to medical appointments. If I look on our behavioral health calendar for our residential program, we probably average 7 to 10 a week. But when we don't have to go outside and we don't have to expose people, we can meet with our provider and do a telemedicine visit. It saved us a lot of money. Our vehicles stay parked 90% of the time. I believe even our behavioral health program now, 85% of our visits are still telehealth. People got comfortable with that, and it works for us. But the one thing about learning to do telehealth early in the beginning was it was exhausting. And most of you can probably relate. Sitting on Zoom for 6 to 8 hours a day is tiresome, where you could have sat and done 6 to 8 sessions or had 6 to 8 meetings in person a day, and you managed, but it was tiring for us, especially in the beginning. For some of my therapists who'd never used it before, we actually started plugging in breaks into our schedule to allow 15 minutes. You do 2 sessions in a row, you're going to have a 15-minute break. Then do 2 more, 15-minute break, and so on and so forth. But I looked at it as whatever it takes to continue to provide that service is what we'll do. Next slide, please. So I want to talk about this launch in a little more detail, because oftentimes when I talk about it, it seems like it's pretty straightforward. But for us, it really wasn't. First and foremost, be ready to learn. When I was sitting in Dr. Polk's office and we were talking about it and, how do we go about this? Who are we going to talk to? Whatever else. The one thing I knew was that none of my staff were going to have a true understanding of what this looks like. They may be gung-ho in the beginning, which I think for the most part everybody was, that because we want to learn, but it's a lot. It's information overload. We had to look at state and federal guidelines, and thankfully, early on in the pandemic, you couldn't really turn on your computer or the news without seeing some new guideline in terms of what the CDC is saying, Medicaid and Medicare. So it was easy to stay up to date, but when you had to move and pivot and change language or change policy, that got exhausting. I look at how many policy changes I've had over the past 3 years, and I think I quit counting after 12. Just adjustments in terms of, oh, do we have to quarantine? Do we have to wear a mask? How long do we have to wear a mask after quarantine or exposure versus actually having COVID? It was a fluid situation for us constantly. Really understanding what your clinical workflow is going to look like. For most of my clinicians, we try to have around 7 sessions a day. That's kind of what, our optimal level is. That still allows for, a lunch and 2 30-minute breaks. Everything's good. When we went telehealth, it dropped down closer to 5 or 6 because we knew the case management aspect of what it was going to take to get people on. I mean, we would have somebody, we'd be talking to them on the phone, looking at our computer, explaining to them step by step of what they're seeing and how that's going to look. So when we handed out these devices, there was instructionals that came with it. We would typically have them on the phone and be reading it with them and have them walk through it on their device the day before their session would happen. So when the clinical aspect or the workflow came into play, it made sense to them. It was already clear, and we didn't have to worry about all the other nuances that came into play with all that. You know, the next step for us was contracting with a secure video conferencing provider, and we picked Let's Talk Interactive. They met all the regulations and compliance for HIPAA and 42 CFR Part 2. They stayed up to date with that. They kept us in the loop in terms of things that we maybe needed to address or not address. They digitized all of our documentation. And they were relatively cheap, you know, so that was a big thing for us, because being a nonprofit, it's not like I had telehealth built into my 2020 budget and all the external costs that come with that. So again, big benefit for us. Making sure our EHR could track and bill for telehealth services, because we're talking about brand new billing codes that we'd never used before. So working very closely with them, letting them know what codes we need, what services are going to be different, how they're going to be built, how we're going to bill for them, how do we acknowledge that in our documentation? Because typically in our EHR, you would start typing a note because everything was in person and at this location. Well, now we've got some people working remotely. We've got clients who are not in person, they're at home. What does that look like, and how do we need to document that so it is something we can bill for? Ensuring all consents are signed. You know, we had paper files before that. We were able to just flip through, yep, signatures on all these lines. Well, now we're going into a table of contents that has multiple documents, and it takes time to click on each one and move forward. Our EHR was able to implement a strategy where it would acknowledge or not whether or not a document was signed. So our, you know, for the supervision purposes, I could just click on a file and see if all of them were highlighted, and that meant that they were signed. But just little things that changed through that time. Training your clients on how telehealth works. You know, I've spoke to that a few different times now, but not only your clients, family members, you know, just kind of bringing everybody in the loop, because when we're working with an individual, well, his family may be getting services somewhere else and they wanted to learn, hey, how do I do this? Is this like this with every provider? You know, and just explaining to them, taking that extra time and being person-centered, you know, family-focused, and just understanding that these are not, our client is not the only one who needs help. You know, it's the whole dynamic, the family dynamics that go on. And again, training staff, you know, measure your outcomes. You know, we track data on people who are seen in person versus telehealth. And initially there were some differences. But I would say now, especially with the amount of telehealth we do, they're pretty much the same across the board. Granted, it leans very heavy into the telehealth aspect, but in terms of our outcomes, we're not seeing really any differences, nothing measurable that we need to be concerned about or address. But also, last but not least, is continue to train. We have a yearly training on telehealth. Granted, we have new incoming staff. We still have the same staff who have been here forever, but you have to approach this like you would any practice. You know, for those of you who do trauma-informed care trainings every year, or confidentiality or HIPAA, telehealth is one of those for us now. Because when I was seeing patients all the time and how I interacted on camera is probably not up to par today, because I'm not seeing patients. I'm doing Zoom, but I'm probably not sitting as close to the camera as I should. I'm not aware of what everybody's doing in their background. Just little nuanced things that I think everybody needs to brush up on. And it's just good for us. That's how we stay at our best. But it requires, you know, diligence and just adding it to that, to your policy and procedures that, hey, we do this every year. Here's when we do it. Next slide, please. And again, just keeping in mind of multicultural considerations for telehealth. You know, people have different needs. You know, we had some clients who just didn't like telehealth. They didn't want to be on screen. They didn't like how they looked on screen. It weirded them out due to whatever belief system that they had. A lot of my clinicians and professionals would talk to them, you know, make adjustments, think outside the box. How else can we do this? Because at the end of the day, them getting the care that they needed was most important. And yes, sometimes, you know, we're supposed to be on camera at all times, but if that was overwhelming for them, we would have them just appear on camera in the beginning and let me know you're there in the end. Whatever we had to do. But I think by now we've worked through most of that and people are accustomed to it now for the most part. But I never want people to forget that this is still new to a lot of people and that they still may have some reservations. Like, who else is listening? Is there anybody else in the room? You know, we do a lot of severe mental health via telehealth. We're working with clients. You know, sometimes we got to take our camera and move it around the room so they can see, so that they are not paranoid through this conversation, that people are listening. You know, helping them understand what kind of encryption we have through our telehealth system to protect their information and what that looks like. You know, just I always want people continually embracing cultural humility. We don't know everything. We're never going to be the expert with other, you know, ethnic groups or tribes or whatever it may be. Always be a student, because that person is unique. You know, you can't work with people and just expect it always to be the same. You know, having cultural knowledge and specific skills for working with cultural issues and form a central component of interviewer competence. You know, so as I bring in new clinicians, we have a whole cultural competency that we go through. And I always tell them, you're still not going to know. But the person on the other side of the screen is the person who is going to know more. So just ask. Forever be a student, and you can't go wrong. But with that being said, I think I've kind of covered everything. So I am open for any sort of questions anybody has. And again, thank you for giving me this opportunity to share.
Thanks, Beau. That was amazing. I'm so wowed. And just the first thing that just comes to my mind, and I'll jump in, is we hear so much about compassion fatigue, especially during the pandemic with mental health clinicians. And so how did you try to balance that with your workforce, who were probably struggling with COVID and isolation themselves, and the Zoom fatigue and compassion fatigue? Was there training that you had for your workforce to keep levels up?
We did a lot of different things, you know, and I'm always looking for input from my staff. You know, what works for you? We would have team building activities. So this is even when we were all working remotely. You know, DoorDash is a really cool thing. It's rather expensive, but I would order DoorDash and send it to my clinicians that I knew were working on, you know, at home. And then we'd hop on Zoom and we'd sit there and laugh and joke, just like we would if we were in the workplace, you know, because that's what people miss. They miss the camaraderie. Every morning we would have a meeting, you know, because we would start seeing patients typically around 9 o'clock. So like 8:45, you know, 8:30, we would meet and just, you know, see what everybody was up to for the day. You know, I think we would do that Monday, Wednesday, and Friday. You know, have a beginning of the week, midweek, and then close out, just to see what people needed. Hey, do you have all the paper that you need? Do we need to have somebody come deliver so you can print some things off? You know, what else are you missing? It was that connectedness that we really strive to keep, because the core group of us, you know, that started in the pandemic are still here today. Like I said, we had 1 or 2 that left, but everybody else stayed tight. But I really attribute that to the extra work we put into taking care of each other. You know, so like I said, we'd have lunches. I would send donuts, just anything that would kind of help brighten people's days. So when they would go answer their door and they got lunch and didn't know they were having it, you know, they felt appreciated. So those little things made a big difference for us.
Amazing. Feel free to come off mute if you have a question, or put it in the chat box, please.
Did you have any problems with training or getting the coders on board with it? Like, meaning, like, do they know that the 421 to 423 is an e-visit? The audio, you can get paid for audio only calls with a 99441. Was that kind of a hard learning curve for you guys?
So we outsource all of our billing. So
Okay.
since we contract through them, it wasn't that big of an issue. I can understand where that could be a problem. But I made sure my clinicians really work closely with them too, like saying, hey, because some of them have never done a telephone therapy session before. So really communicating with our billing or, our outsourced biller that, hey, on this session, this is what I was doing, because like I had stated, some of this was learning on the fly. So it wasn't like they could just submit a note electronically and it would go and get billed appropriately. We were calling and touching base with them. And again, that led to some of the frustration with clinicians because they never had to do that stuff before. But I would tell them, I can't go into the EHR and tell what kind of session you had if it's not written, if it's not coded and done correctly. So, a lot of hands-on and putting some extra work on some people is what it took.
Yeah, I'm from Alaska, and we've been doing telehealth up here in telemedicine for 20 years. So when COVID came out, the joke was, oh, we've been spending 20 years getting ready for this. But like, we were using it, like we found like a lot of usage in like cardiology for one, because we have Afghan carts with like otoscopes and EKGs on them. So they can have, it's just cheaper to, instead of flying a cardiologist out the Aleutian chain, like a 3-hour flight, or flying the patient in, it's just cheaper to do it that way. But yeah, behavioral health has always been a huge one for us. And like even dermatology, where you could take a picture and then the doc could send it in, and then they'd be like, oh yeah, you need to be seen or whatnot. But like, have you worked with like a lot of the different ways like that you can get reimbursed? Like you have the interactive way, which is face-to-face like you and I are right now, but then you have store and forward, where I was talking more about like dermatology. And then a lot of what we're doing up here is like self-monitoring. We even have, so in our EHRs, we actually build the pick lists and codes for the providers. And it's a lot of training with the providers and on how to document it and trying to put those in easy grab spaces. But what we've realized, especially during the time of COVID, I'm working with 20 or so different tribes in the countries, helping them set up these telehealth programs, is they're leaving a lot of money on the table, meaning they because they're not trained in documentation, they don't realize that they can get paid for audio only, text, email, e-visits, all the gauntlet. It's just a matter of showing the providers this is how you document it, but also a matter of letting the patients know. And I don't think even in May 11th or whatever that date is that they're going to do away with the public health emergency, I don't think this stuff is ever going away. Meaning having the patient go back to like, oh yeah, we don't have an appointment for you, but we can schedule you in a week or two. They're going to be like, well, what about the doohickey where I can just text you or email you? they're gonna love it. I think this is like you were saying earlier, the silver lining. I think this was a huge silver lining of COVID, that we kind of pushed us into this cool new world where we can actually utilize these tools and get reimbursed for it.
Mm-hmm. Yeah, Indian Health Service is one of the pioneers of telemedicine, because, when we talk about working in Indian country, we got people spread out all over the place, and you try to put hubs in places and like, they still don't have access. So they started that well before, like you said, 20 plus years ago. And now we're finally catching up and utilizing the information that they tried telling people, decades ago. Because I know Indian Health Service saved hundreds of thousands of dollars the first year that they implemented it, and they were doing very little. But yes, to add on to what you were saying, this is not going away. And I am so grateful for the ability to reach out to different people we never would have served before, the access to get to them, and it was just this past year, we went out and bought more tablets and phones, through another grant, to give people with another free year of service. Because as we know, when you go to some of these reservations, it's like the black hole. I mean, I used to go up to Macy all the time, and I knew as soon as I crested over that hill, no communication. Like my cell phone is basically worthless. Now they've gotten broadband and things have improved, but it was still the idea. I didn't want any of our clients to go anywhere where they didn't have that access. I mean, we had people sitting out in our parking lot early in COVID because of the Wi-Fi adapter we put outside so they could connect to it and we could still do, therapy sessions. There was a lot of different things we attempted and did, for certain periods of time just to get their needs met. But in terms of your comment about billing, you're 100% right. There's so many new billing codes and different ways to do this and do that. And it was a learning curve. A lot of my staff, my case managers we never thought about billing for case management. Well, now that there's certain things that they do every day that we bill for.
Yeah, I remember in the beginning too, going back with CMS and HHS, like for years, like you were saying, for years we were fighting for, hey, can we get paid for an audio visit? Let's say a patient calls into a doctor, can we get paid for that? And they're like, no, it has to be audio visual. And then when the pandemic came, they're like, all right, yeah. But that was a huge win for us because, I mean, we have elders that, I'm working at Navajo Nation right now and San Carlos Apache and Gila River and these places, but they have rural places just in Navajo where there's not even like running water and you're expecting them to have like FaceTime with you and with a laptop or something. So when we got that was a huge win that we were able to schedule these just even telephone calls and actually get paid like a face-to-face visit. Mm-hmm. And I mean, I think we just need to expand this and show everyone how to do it and really share our knowledge on this because it is like I was saying, you're saying it's not going away. And there's a lot of opportunity to reach people that we would never really have reached before.
Well, and just the capacity to build, working in the nonprofit sector, we were injected with a lot of money. Now, a lot of that was needed, but there was a lot of it that you could use to scale programs. And I was very fortunate to have support, from our CEO to actually do that. Now we have peer support, our transitional living program was jump-started just because people needed a place to go after treatment and we needed safe environments to refer them to where we could keep them safe. So again, negative initially, but there were a lot of positives that really built programs up that gave us the ability to do those things. So.
Great. I'm going to jump in with a question from Tania. She asked, did you experience pushback from any staff to use telemental health technology to provide care? And if so, how did you get buy-in? She's experiencing pushback from medical staff that still prefer to be face-to-face.
So, and it's double-edged because you have to understand what it is that your client base needs. And if the demand is there to be seen via telehealth, which obviously for us it was because we were going to shut down. We knew at some point it was just going to go black where this is it, your only option. I drew a hard line in the sand. And whether that was the reason one or two people left, I don't believe that was the reason. I think it was just overwhelming. But that was going to happen. And I had to draw that line because what I didn't want to do was figure all that out that they didn't want to be here after the fact when we're already remote and now I got to go find a clinician and retrain and everything else. I wanted to learn that in the beginning and, talk to any of my staff. I'm a person who always listens. I'm going to take your, concerns into consideration. We're going to talk about it. But at the end of the day, a decision has to be made. And I err in favor of our clients. And if that's what they need, that's what we're going to give them. That's what we're here for. None of us would have a job here if we weren't meeting the need of the client. And that's, again, I drew a line in the sand. And I can't remember, it was probably the end of April, something like April 20 something, that I finally said, we're going 100% remote because the shutdown is happening and we're going to start it now. So it was like a week before, we were prepping clients. This is where it's going. It's going to happen. This is what we're going to need to do. So that's where all that case management work happened. But again, that was all hands on deck, all staff, that you didn't really have an option. The train was leaving that station and you had to be on it. And again, it worked out for the better. So.
Great. We'll take one more question. I see Dr. Fowler has her hand raised. Dr. Fowler, you can come off mute.
Thank you. I just had a quick question regarding something I've heard from other UIOs as we're thinking through some of the inaccuracy of data for urban Indian organizations and the reporting that they do for IHS. And I was wondering, did you have any challenges around patient counts when it came to telemedicine versus telehealth visits? Because it seems to be one is favored, or I don't know if the word is favored, but one is seen as a visit over the other in certain types of reports. So for instance, if there was your GIPRA report versus your end of year workload reports that you might have to do, depending on the denominator, telemedicine or telehealth might be not considered in those equations. So I was just wondering if you have seen any inaccuracies in your numbers and your counts.
You know what? We ran into that initially a little bit, but we work very closely with our IT department and review consistently, because you're 100% right. The reports we were running in 2019 and were very basic in terms of all in person, this or that. Where in 2020 now we have telehealth. Were those numbers going up, or were they all being captured? Thankfully, since we have an telehealth platform that also documents, I'm able to compare and contrast what is reported in from just our electronic health record to that. So I can kind of see, yep, those numbers are close, or whoa, we're missing something. Where'd we drop the ball? And, like James was kind of saying before, you got new codes and everything else. Were they capturing all those codes? And are those codes being calculated appropriately? Because like with peer support, their typical standard code is for 15 minutes. Well, they met for an hour. Did that count for 1 or did it count for 4? So a lot of nuance. But I have a monthly meeting with our EHR and our IT, and we all sit in the same room, because we've watched people run into that, and I try to be a little ahead of the game and track that monthly, and then they have to answer to it. And if we're missing something, they go back and look and find out where it's at. But it's not something you can do at the end of the year when they're really wanting those numbers and know that it's going to be accurate, because you're gonna run into some sort of problem.
Yeah, I think that's, you hit it on the nail on the head. Like, that's also some ways in which the monthly reporting is easier than waiting to the end of the year to kind of gather that information. But I also understand, you mentioned your EHR system, and I wasn't sure, are you on RPMS or some other off-the-shelf system that you're using?
So we go through custom computing here in Omaha. Dr. Polk was against RPMS in the beginning, because it's kind of it was an old system. Now, of course, they're changing everything, and we just dumped a bunch of money in our EHR, but they've been working with the data warehouse, and they have their own transmission line and all of that put into place. I don't plan on switching, but since now we have such a history with them, we're kind of able to make adjustments, and it's customizable, which is the huge benefit to us, because we used to use AccuCare. It was non-customizable, and it was kind of drab, but a lot of people in the Great Plains use it, because AccuCare went through the process of creating that channel so they can do their data dumps. But yeah, when you talk RPMS, that's out of my scope, but using a customizable EHR.
And with
Thank
that,
you, I appreciate it.
We're at time, and this is a great discussion. I wish we could continue, but it's already 3:01. So I just really want to give a big thank you to Beau for leading such an important discussion. I hope so much has come out of this. And next slide, please. I just wanted to share some other events that we have coming up, and also our evaluation. If you have a smartphone, you can take a picture of our QR code. Molly will also drop this link into our chat. But please fill out our evaluation. It helps us to plan for future events and make improvements to the events that we have. And last slide, please. And we hope to see you in an upcoming NCUIH event. All of our events can be found on our website, and you can register for events there. And please keep in mind, most importantly, the save the date for our national conference or our annual conference, which will be Monday, May 15th through May 18th. And we hope to see some of your faces there. And with that, again, thanks everybody for joining. And a special thanks to Beau for leading this session. Really appreciate it. Have a great day, everybody. Oh, 1 second.
Liz, if you wouldn't mind sharing my email address. I saw there were some questions in the chat wanting to talk to me. If you could share that information with everyone, I'd appreciate it. I added my email address to the chat, but
Awesome.
you know, if they want to follow up with me, that'd be fine.
Yeah, let me, I don't see it in there, so let me just pull it up.
Oh, I must have did it direct message.
You might have done a message to somebody else, but I will pull it up. Let me see.
There you go.
Is it going? Yep, perfect. And with that, thank you, and hope to see you in a future event.
Thank you.
Bye, everyone.